kick off and go from there.
Great, thank you so much. I'm very happy to be here and to share a little bit about Curemark. We're founded in 2007, specifically to look at autism and then other unmet medical needs. And as you'll see, we have a large patent portfolio. We have multiple targets, but we've done clinical trials now for just over 10 years, and we still have children who are taking our drug in a long-term open label. And our plan is to submit our drug application towards the end of this year. So we had some really good results, and I'll share some of that with you. This is founded in 2007. Our first drug, called what we call CMAT, has a fast track status, which means you have lots of interaction with FDA through the development of the drug. It's biological, so it has tremendous protection, 12 years once it's approved. And we have lots of things in our pipeline. And it's what we found is a platform technology, and it's based on a gut-brain connection. This will be the first gut-brain drug that is approved. When we first started this work, people were thinking about gut-brain with kind of a scowl on their face. And now with all the microbiome things and other things out there, we understand now that the gut-brain connection is really important. And especially for the development of drugs, of which, there haven't been any. So let's see here. When you put that out, okay, there we go. So we have patents in these areas: psychiatric, neurodevelopmental, gastrointestinal, addiction, and infectious disease. And we have them worldwide. It's over 300 now. And we started with autism. We will now go into schizophrenia and Parkinson's. As you can see, those are our lead candidates as we move forward. So autism is a spectrum disorder, and we'll talk about that a little bit in a moment. We don't know what causes it. There are some people who were convinced they would have the genetic underpinnings of it, 7, 8 years ago. We don't have that. There are multiple genes that have been identified, but we don't have any cause. As Marty said, there's better diagnosis, but that's not what's attributable to more autism. That's kind of been shown that that's not where it is. There's a lot of disparity in the area where people are trying to figure out what causes it, how to deal with it, how to treat it, how to help the kids because then become now adults. So it's been a lot, but because it's a spectrum disorder and the children are different child to child, what was interesting to me while I was in practice seeing these kids was that it's what they ate. What they ate was more similar to each other than their autism symptoms. And after some initial work and looking at kids with autism, without autism, because their diets were identified as white and tan, and it really was very, very high carbohydrates, very low protein. And what I found was that these kids are low or missing an enzyme that digests most of the protein that we eat, called chymotrypsin. And that then started the first patent and all the rest of that from there. So we truly have a gut-brain connection because this digestive enzyme, or these digestive enzymes that digest protein, are really important in terms of neurology and in terms of amino acid that actually build new proteins, especially neurological ones. So in our drug and in the body, you have these 3 main proteases: trypsin, chymotrypsin, and elastase. And the blue is essential amino acids that they cleave, the yellow semi-essential, but you need to have food that breaks down into amino acids in order to get those amino acids in the body. So the amino acids that you take, these bodybuilders and everyone takes amino acids, they just go right through your body. They go right through the GI system. They're not absorbed, only in tiny, tiny amounts. But the body breaks them off in ways that are specific for their uptake channels in the gut. And so having them cleave this way is really important. Tryptophan forms the basis of serotonin. Phenylalanine forms the basis of dopamine. So really important amino acids. We think of amino acids as building proteins, but they also turn on and off certain genes. So like, for example, the CHOP gene, which is associated with what they call neural pruning. So we are all born with too many neurons in our brain, and the body cleaves them and prunes them over time to get our adult brain. Methionine, which is also broken off by the chymotrypsin, actually controls the CHOP gene. So these essential amino acids are important both as controllers as well as building blocks. So the amino acid pool that you have is really important as you move forward in life, because they do they do lots of things. So with autism, initially we saw a lot of it in the US, a lot in Europe, but I have pretty much traveled the globe now, China, Qatar, Australia, and there's a lot of autism sort of everywhere. Africa now talks about a lot of autism. So there seems to be more and more of it. In some places like China, it's really becoming more front and center. Parents kind of hid their children before. Now there are special schools and other things to work with the children. And so, but the prevalence is thought to be 1 to 2% of the world's population has autism, whereas about 5% has schizophrenia, believe it or not. So there's a lot of individuals with these conditions. So these are the pieces of autism that are out there. The ones in green are basically the main symptomatologies that you make your diagnosis from. And then you add seizures, disorders, and GI issues. And you have this whole panoply of symptomatology, all in different places. So some kids don't speak at all. Some kids have great expressive language, but they don't have any receptive language. So when they speak, they don't really speak about anything that they are asked. You can ask a question, they don't understand it, they just speak. Others understand everything, but have difficulty expressing. So there's a lot of variation. And basically the current therapies are behavioral ones for the most part. There's never been any money in autism treatment until recently, where some of these big private equity groups have picked up behavioral interventions, groups that do that. The US only has risperidone and Abilify, which are very, very black box warning antipsychotics. And then everyone uses everything off label. During our trials, anything that was sort of south of South Carolina, kids imported things from Mexico. So we had to see what they were taking and have them translated. There's no standard of care, which makes it a difficult condition to treat. So about 90% of your brain development is done by 5 years. And that's a really important period of time. It's where your serotonin is made in the brain. Your brain growth is pretty much, at its final place. And so those early years are important. The children with autism sometimes you're able to diagnose it below 3 years of age, but for sure by 3, you can diagnose it. Some kids show signs early on and they never change. Some kids show signs that someone might say, oh, gee, that looks autistic, but then by 3, they're fine. So 3 is the age pretty much. And as you can see, the brain growth there. What's interesting is that the brain manufactures the peak serotonin manufacture in the brain is from 0 to 5 years of age. And we see here that autistic kids don't make the same amount. They make less. So they're starting out at a deficit. And the point of our drug is to give them the proper amino acid pool that will get to the brain so they can make more serotonin. So you see that gap there, it's pretty large. And serotonin is made in your brain and your gut. By the time you are 5, or actually by the time you are 2, you can't take any of it from the gut because of the gut-brain, the blood-brain barrier in the brain. So you have to make it yourself. So there's that place between 3 and the end of the 5th year where you start to have a problem. So we did quite extensive clinical trials for autism. We did 2 double-blind randomized placebo-controlled trials and then continuation trials from both of those. Now the kids are all in one continuation trial. And we did it with just the low levels of the enzyme, and then we did it with kids with all levels of the enzyme. FDA wanted us to see who might actually benefit. We did it in the US only at some of the best centers: UC Davis, UCSF, Yale, Montefiore here in New York. We did it mostly in these kinds of centers that are either hospital, university-based, or standalone like SARC. But still, state of the art and centers of excellence for autism. We also did it in 2 pediatric offices that do clinical trials to see if there's any difference in how the kids responded in those settings, but there was none. So we feel very good about sort of our drug. The safety was amazing. We've given over 700,000 doses of this over 11 years, and we had no related serious adverse events at all in all this time. So, the AEs, are mild. In the double blinds, the placebo kids had more than the drug kids. So that was associated with their condition. So here's some of the, long-term outcomes. This is in the first trial we did. This is looking at irritability, agitation. You see in all of these psychiatric trials, you're always going to see a placebo effect early on, but then that placebo effect reverts and you have efficacy. Irritability is an important piece in terms of, and I'll show you why in a minute. And then there's socialization, same thing. You've got reversion after a placebo effect. And then, the kids have statistical significance. This to me is probably the most important slide or the most important piece of data we have. The red represents the placebo kids in the double blind over 12 weeks. And the blue are the kids in the first 12 weeks who were in the double blind, and then they continued on. If indeed you have a drug that shows efficacy in a double blind, but really as a result of another effect, or just a placebo effect, or just some sort of knowledge base around the drug, immediately after the kids go in the open label where they all get the drug, the placebo then literally gets right on top of the blue line here on the bottom where the drug kids were. So immediately what you see is what everyone's experiencing. But in this situation, it doesn't catch up with itself. I mean, it may add 108 weeks or 10 weeks or something like that. But in those first, sort of 2 years, they don't really catch up with themselves. And that's because it's a neurodevelopmental condition. So, you've given a drug for 3 months to a 3-year-old. Their development is going to be different if they were on the drug versus placebo. And it takes them time to catch up. So what you see is a continual decrease and betterment of symptoms, but they don't catch up to the drug. Here you see it catches up at 84 weeks, but socialization is a secondary type of effect. So while it's a primary symptom, we believe that it comes and its betterment comes after other things get better. So you have irritability and agitation. When that goes down, the child begins to have more speech. And that communication then allows them to be more social. So you've got multiple things going on at the same time, just like you do in all the pediatric development. So irritability gets better, then speech, then socialization. And we presented these findings to the big autism meeting in 2019, I should say. Manufacturing is an outsourced model. We had some Interesting things to deal with in terms of manufacturing. We have an enzyme that needed to get through the stomach and then be released right after it got out of the stomach. Other enzyme preparations, like for cystic fibrosis, have to be delivered much later. They can be coated differently. We imported our coating from the food industry, which made it, we believe, even safer than others. 3-step process. We get our enzyme, it's formulated how we want it with high protease. Then it goes to the coating and then it's packaged. It looks like this, it's granules that's sprinkled on food. The markets are large, right? There's lots of autism. Our goal is that every child will get this drug. What will drive it is the large unmet medical need, the awareness, of course. There's no standard of care, which I think in this case is very important. You've got a major unmet medical need with no standard of care. So if a child is diagnosed with cancer or with muscular dystrophy or any numbers of cystic fibrosis, they go to a center of excellence and the prescription for treatment is basically the same. And but in autism, it's all over the board. So we believe when a child is diagnosed at 3, they can begin to take our drug. And that will become the standard of care. It's a complicated formulation. We had Booz Allen, the old Booz Allen group, do some work for us, looking at growth, uptake, that kind of thing. I'll pull out just the US here. This is going through ages 3 through to 15, looking at how many kids, what's the prevalence, what's the diagnosis rate, all of those things. You're looking here at, low penetrations, peak penetrations that are low, and you can see the large numbers. And so we believe that there's a lot of opportunity to get this, just not only approved, but out in the marketplace. We see the net revenues being large in multiple areas, all starting at different times, as it's a global issue. Our valuation has increased as our patent portfolio has increased, as we've begun to get, milestones in our trials. And that's us. We're excited to be submitting this.
Joan, if you can hold on 1 second, I'm going to end the polling and release it to you. You can take a look and answer the questions. Just give me 1 second.
Okay.
Joan?
Yes.
I've got a quick question for you while Marty's compiling the results.
Yeah, sure.
I'll follow up with you offline because I don't want to get too personal, but I have a 12-year-old son who's at the most severe. He's verbal, but he's at the most severe end of the spectrum. Everything that was in green in those bubbles, yes, and the outliers on the side, no. And he's been in a residential school 24/7, 365 since the age of 5, so 7 years. I think I know the answer already, but is he too old? Can this enzyme help him?
I don't know. The thing I can tell you is that we directly enrolled some children who were 9 to 12 in that range, and they did well.
Oh, so in other words, the idea that by the age of 3 or 4, it's a diminishing return situation, is there merit to that? Or
I think so. We had our best. So we didn't do a classic dosing study here because the enzymes, are around how much food you eat. But the younger they were, the better they did. So the 3 to 5 group did better than the older group. But when we look at them over a longer time than the 12 weeks, they continue to improve. So, we didn't actually look at that per se, but, if you were 22, I would say that's one thing. But at 12, I don't know.
I will follow up with you
Okay.
offline, but I'm determined to get this to him sooner rather than later, even prior to the FDA. So I will stand outside your home.
I'll give you her address, Michael, later. No.
You won't be the first.
I appreciate it.
Will not be the first.
Joan,
And
you can see the results of the polling there, but so a lot of people are just interested in like, what's your timing for this? What's the current capital stack?
yeah.
Et cetera. So if you can just dig into that a little bit, that'd be great.
So, right now we're at a point where we're trying to decide whether to do an IPO or remain private, or an M&A. And, to me, it's about two things. It's bringing value to the investors, and it is also to get this drug to the kids. So we have to consider all of that. We can launch this drug if we have to, and that's how I sort of raised the company. I'm a pediatric development person, and I know that if a kid, improves all of their domains, even if it's slowly, their prognosis is better than having one area of their development lag behind. So I made sure that nothing lagged behind for us. So we are currently in a $30 million kind of pre-IPO round right now. I can, discuss that in terms of what else goes along with that, and, offline. And trying to, decide with the bankers what we're going to do in terms of, it's a great, one of the speakers before talked about a great time for healthcare IPOs, and it is. We just have to, think about what's best for everyone, investors and these kids. So, and also we know that people don't do M&As anymore in this field without, saying we're going to go public first. So those are all considerations that we have right now. And the exit.
I just need to do one more thing, but if you can just give us more information, like if your contact information, your senior management team, I'm not sure if you discussed them, but pull it back up.
I did not. So
yeah.
the team has been with me for a long time. So we have a chief scientific officer who is a PhD in immunology. He's been with me. He helped design the coding, doing all that. We have a CPA, Jennifer Catritos, who's a financial person. We will get a CFO on top of that. We have a team of incredible researchers who have done these trials with us. Kristen Walsh is a senior nurse researcher, and has done this work. Our chief medical officer, Bill Gannon, has done a lot of drugs over time. We have a lot of consultants that work with us every day. Our lawyer is outsourced, but we talk to him every day. I mean, it's like having an in-house counsel.
Yep.
So we've done this. Yeah.
Fantastic, Joan. Well, listen, I really appreciate it. And do you have like a one pager or like, I mean, how do people get like,
I do. I have a one pager. I can send it out.
Or like, do you have like a web page that's
Sure.
just dedicated to IR?
It's on the screen here. The web page.
Right, but
My email is
do you
there.
have like a curemark.com/IR? Like with announcements?
No, but if you go to info@curemark. Curemark.com, we'll get that.
Yeah. Do me a favor. Do me a favor, Joan. Put together a page that's an IR page.
Yeah, we have one.
When we do a post on this event, I'm going to share the poll results, and then I'm going to put out an announcement to my 65,000 LinkedIn followers about your firm. It's just to make sure they know about it, because obviously, as I said, the diagnosis is